Καλημέρα σε όλους. Να ευχαριστήσω τον Πρόεδρο, να ευχαριστήσω τον Γρηγόρη και την Οργανωτική Επιτροπή για αυτή τη τιμητική πρόσκληση και να προχωρήσουμε γρήγορα στην παρουσίαση. I will do this presentation in English to the international faculty, and we will talk about OCT image interpretation. So, the reason that we now know what to say about OCT and how to interpret it is due to several international meetings that have been called in the past and have made some definitions, some consensus regarding the way that we should interpret the OCT images. This is how we have derived our knowledge regarding the morphology of atherosclerotic plaques by OCT. So, in order to begin, I would say that we have several features that we can reliably detect by OCT. And this begins by the normal vessel wall, by the presence of atherosclerosis, and the presence of thrombus. And everybody that deals with OCT must be quite acquainted with this image. Why? Because this is the image of the normal vessel. If you don't have this image, then you have some plaque. It may be mild, it might be some pathological thickening, some pathological intimal thickening, but still, you have to have this thin, bright layer in the at the luminal surface, this darker layer in the middle, which is the media, and then this outer bright layer that corresponds to the adventitia. Now, moving on to plaque buildup, we have the fibrous plaque. Fibrous plaque demonstrate this bright layer within the intima and this morphology that's quite similar to what we saw before, but of course, we have a thickness that exceeds 500 microns. But when we have an extensive accumulation of plaque, then we do not actually see behind due to the depth. I remind you that the penetration of OCT within the tissue is lower than the one of IVUS. So over 1 millimeter, 1.5 millimeter, we cannot see that clearly. Of course, most of the cases, if it's quite thin, then we can also see the external elastic membrane and the media can be clearly visualized. Regarding the fibrocalcific plaque, this is something that we can still see with quite high confidence, and it is actually this low-intensity area, this area over here, that has a sharp delineation compared to the inner fibrous layer. And the other characteristic is that it has low attenuation. Low attenuation means that you can actually see behind it. As you can see over here in this panel, you can clearly distinguish behind. And this is the main difference between lipid and calcium, as you see in the figure in the right, where you have this calcium superficially, but also here where the yellow arrows are, you have some lipid. You can see here the difference, a very diffuse signal attenuation, a very diffuse drop of signal intensity, and a high attenuation compared to here that you can see actually very well behind. You can even see the media at this point. And then we have the lipid, that we can say that we can see it. And there has been much controversy whether we can actually see the lipid or we can see necrotic core. The truth is that most histopathology studies have corresponded this to lipid pools. It could be necrotic core, it could be just some extracellular lipid droplet ogglucan deposition. But this is a typical appearance. You have this very diffuse darkening with this loss of attenuation. And over the lipid, you can see the fibrous tissue, you can see a cap that's overlying this pool. And you can measure the thickness, which in several cases may be quite thin. And of course, plaques do rupture, and in this case, you can see a clear separation of the fibrous cap, and then you can have a cavity formation with or without thrombus, if it's healed. On the other hand, we can actually detect erosion, but not with a typical way that we are used to, that we have learned from histopathology. So histopathology sees an endothelial denudation. OCT does not have the resolution to see endothelial denudation, but we can say that we have erosion when we see some thrombus attached to the fibrous plaque in the absence of a rupture. And then, of course, we can see with a high confidence thrombus, which are these intraluminal masses. They may also be attached to the vessel wall. And we have two types of thrombus. We have red thrombus, which consists mainly of red blood cells, and white thrombus, which consists mainly of fibrin and platelets. And the difference is that although they have the same intensity at the beginning, the red thrombus has a very high signal attenuation, meaning that you cannot actually see behind this thrombus. And then we have macrophages. These were first detected in MGH by a special software, but we have also seen it in clinical practice. They have been used as an endpoint in several studies. And what we see is this very bright spot at this point, causing a very high signal attenuation, giving an appearance which resembles quite a lot to necrotic core, to lipid pools. And then we have things that we do not have that much evidence about, and these are things like cholesterol crystals, which are these very bright reflections within the intima, or intimal vasculature, when we see that there are some vessels that are moving within the intima, some signal void regions. But of course, using it in vivo, we have seen several more features, such as a thrombus that has been recanalized, causing this classic honeycomb-like appearance, these multiple tissue rims within the lumen, separating it in multiple channels. We can see spontaneous dissection, where you can actually see a false lumen and a true lumen, and you can discern the layers, the media, and the intima within the true lumen. And of course, in many cases, this can be accompanied by a submural hematoma, like in this case. You can also see it in the longitudinal reconstruction. Another feature that has been described, again, histopathological evidence is rather limited, is the layered plaques, where you can see that within a fibrous layer, you have the formation of a different intensity, sorry about the advances, of a different intensity fibrous layer, showing that there has been something that has been created here at a later interval, and this can be described also as one of the mechanisms of plaque progression. Then when we go to stents, you have to know that when we have a stent, when it's in the lumen, it's this very bright spot, causing this signal attenuation. You cannot see anything behind. You can only visualize the surface of the stent. And regarding that, we say that we have malapposition when we have a distance of the stent from the vessel wall, which is larger than the strut thickness. We can also see sometimes thrombus or tissue prolapsing from within the stent to the lumen. We can also see dissection, which is the separation of the layers of the tissue wall at the edges of a stent. It may be intimal, but it can also extend to medial or adventitia, or we can have a hematoma, as we saw earlier in spontaneous dissection. And of course, in the follow-up, we can see the coverage. Well, coverage, it's not actually known whether it's true endothelial coverage or coverage by fibrin, because OCT cannot really make this distinction, but still has been described. Then, of course, we have restenosis, which is tissue on top of the struts, and several types of restenosis have been described: homogeneous, heterogeneous, and layered. And of course, all the features that we saw before in atherosclerosis, we know the last 15 years that they may also develop within a stent, and we can see all the features that we have seen in classical atherosclerosis within the stent, having the image of neoatherosclerosis. Of course, with OCT, we have several artifacts. NERD, just as in IVUS, multiple refractions is bright signal here. Saturation, when we have a strut, we may see some light behind it. And of course, because it's a reconstruction, we may have seam lines when the catheter moves within the image. Then again, when the image go beyond the field of view, we may have fold-over artifact like here. When we don't have a good flashing in the lumen, we may have some shadows over here. Or when the catheter is too close to the catheter wall, then we may have a tangential signal dropout, suggesting that there is here a lipid pool that is not really there. And of course, when we flash the inside of the catheter, we can see much better. Thank you.
That was a very nice illustration of all the different plaque characteristics and all the different imaging features during OCT imaging. As we saw, all these images are perfect in terms of having very good quality. So it's important to stress that we have to flush out the blood with contrast in both times. So in your practice, what do you do in order to secure that you have a very nice and a very good quality image during OCT?
Thank you, Michalis, for this question. Indeed, having good conditions is essential in OCT for good imaging. And the first thing we have to do is always secure that the inside of the catheter is purged before its pullback, that we not see any gray thing that corresponds to the blood that accumulates within the catheter. And the other thing we have to do is ensure that the guide catheter is well engaged to the coronary ostium. If we have a good engagement of the catheter, we do not even need to have a very high flow rate. We can do an LCA with 3 ccs per second. I think this is the most essential thing in having a good quality pullback.
Do you prefer to use an assist device or manual injection?
Well, in our lab we use an assist device, but it can also be performed with manual injection. I wouldn't recommend it for a routine practice, but it may be done and can also be done with sufficient quality.
For your excellent presentation, Dr. Karanasos. One quick question. We know that the limitation of the OCT is that it doesn't work in big vessels, right? Do you personally have a cutoff limit that you say that, okay, the vessel is higher than 4.5, so I won't use it, I won't have good images? Do you have a personal cutoff point?
Well, I have also used OCT in renal arteries, which go up to 8 millimeters. But of course, we know that the field of view may be quite limited. I would say around 5 or 6. But with knowing that I can get a good flashing of the vessel, I do not have any flow artifacts within an aneurysm that would limit the quality.
Now, I would like to invite